Hello everyone, welcome to the series on oral habits in children. In this video, we will learn about thumb sucking, its classification, clinical findings, and management. The sucking reflex is the first coordinated muscular activity that occurs during the oral stage of development at around 29 weeks of intrauterine life and disappears at around 1 to 3 years of age. It is essential for fulfilling both psychological and nutritive needs. The child experiences pleasurable stimuli from lips, tongue, and oral mucosa and learns to associate these with enjoyable sensations such as fondling and closeness to the parent. Babies who are restricted from this due to disease or other factors become restless and irritable, and this may motivate them to suck on their thumb or finger for additional gratification. Thumb sucking is defined by Moyers as repeated and forceful sucking of thumb or digit with associated strong buccal and lip contractions. It can be classified as normal or abnormal thumb sucking. It is considered normal when present during the initial 1 to 2 years of life, as it usually disappears when the child matures without causing any malocclusion. However, when thumb sucking persists beyond the preschool period, it is considered abnormal. It may lead to malocclusion and other dentofacial changes if not managed timely. Abnormal thumb sucking can further be subclassified as psychological or habitual. Psychological thumb sucking involves a deep rooted emotional factor such as insecurity, neglect, or loneliness. While in habitual thumb sucking, there is no psychological association and the child performs the act out of habit. Now, coming to the clinical findings, the maxillary arch presents proclination of incisors, increased arch length, increased anterior placement of maxillary apical base, increase in clinical crown length of maxillary incisors, increased counterclockwise rotation of occlusal plane, constriction of the maxillary arch, and decreased palatal width. In the lower arch, there will be retroclination of incisors as they experience a lingual and apical force, increased intermolar width, and the mandible gets more distally placed relative to the maxilla. Coming to the interarch relationship, there will be decreased interincisal angle, increased overjet, and decreased overbite. Even anterior open bite occurs due to remodeling of maxillary alveolar process and vertical displacement of maxillary anterior teeth. Along with these, functional posterior crossbite can develop as thumb sucking lowers the tongue and decreases the pressure exerted by it against the palatal aspect of upper molars, while the circummolar muscles contract and increase the pressure from the cheeks. Also, there will be increase in unilateral and bilateral class 2 situation. Extraorally, the patient will present lip incompetence with hypotonic upper lip and hyperactive lower lip. The tongue will be positioned lower with increased lip to tongue resting position and tongue thrust as an adaptation to anterior spacing. Now coming to the management part, the interceptive treatment depends on patient's age, emotional and psychological state, cooperation and motivation of parents and child, nature of occlusal changes, and associated functional adaptation. For children under 4 years of age, periodic observation is generally recommended. This is because the habit is considered normal during the first 2 years of life. Effects of the habit on occlusion are not permanent if stopped by 4 years, and it is difficult to get cooperation of the child for any interceptive treatment. However, if the habit persists beyond 4 years of age or increases in intensity with adverse dental and skeletal changes, corrective measures need to be taken. For children between 4 to 6 years of age, psychological counseling, reward therapy, and reminder therapy may help to control the thumb sucking habit. Counseling involves discussion of the problem and its adverse effects. The child is asked to keep a record of each episode and report on the progress in stopping the habit. Parents should be advised not to nag or punish the child as it may create more tension and further intensify the habit. Parents should consent to disregard the habit and not mention it to the child for a more successful outcome. In the reward therapy, the child must be given a prize such as a star on the calendar for each day he or she refrains from the habit. The rewards should be progressively enhanced so that they remain valuable to the child. If the child ceases the habit for 3 months, there are good chances of stopping the habit and enhancing occlusal development in the long term. Reminder therapy involves negative reinforcers such as distasteful agents applied over the offending finger, long sleeve nightgowns and mittens, and elastic bandage wrapped across the elbow. The reward and reminder therapy may be useful in some children above 6 years of age. However, the habit is so much ingrained that it often requires direct appliance therapy. This includes habit breaking appliances such as palatal crib and bluegrass appliance. So, that was all about thumb sucking. For more information on the topic, you can download our app where we have uploaded detailed notes on oral habits. In the upcoming video, we will look into another oral habit in children. Till then, if you found the video helpful and informative, then do like the video, share it with your friends, and subscribe the channel for more such content.